Good evening, everybody. Welcome to my YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and thank you so much for joining me tonight. Tonight, we're going to be talking about cholesterol. And this, by the way, September is Cholesterol Education Month, so I didn't want to leave this month without having a little input on cholesterol. Now, I'm just not going to be one of those boring talks about HDL and LDL. We're going to dive a bit deeper and kind of tell you about what's happening, what's new, what's old, and really what you need to be thinking about. But first, a little bit about basics. We have to start with basics, right? So if you get if your doctor orders a standard lipid panel, what you're going to get is total cholesterol. You're going to get LDL cholesterol. LDL basically is low density cholesterol, or what I call lousy cholesterol. You're going to get HDL, which is high density cholesterol, known as healthy cholesterol, and triglycerides. That's it. That really is the standard panel. And so many decisions are based on that and nothing more, which of course I find pretty upsetting in this day and age where we know so much more. Now, you've probably also heard from your doctors in the past that lower the better. The lower the LDL or lousy cholesterol, the better it is. You're less of a risk of a heart attack or stroke. And higher the HDL, the better it is. So, but I'm here to tell you that's not completely true. And you have to know a bit more than what that's all about. So the important thing is not about how low you can get. And I'm always talking about this. It's about knowing your risk. So to me, knowing your risk is a heck of a lot more important than how low you get your LDL cholesterol. So let's talk about who's high risk, right? Because that's the most important way. That's where we should start. So high risk, okay, the obvious people that have known heart disease, people that have had a previous heart attack or stroke, they've had coronary interventions such as stenting, balloon angioplasty, open heart surgery, bypass surgery. Those are your obvious. Also, people that have peripheral artery disease, disease in their lower limbs, or carotid artery disease, disease in their carotid arteries, because really it's the same process. Plaque is plaque. The process is the same, it's just a different location. And we know for a fact that people with peripheral artery disease and carotid artery disease are high risk for heart attacks. So we treat them aggressively as well. There's another class that's the diabetic population. And it's the reason why diabetics, about 70% of diabetics will have a heart attack or a stroke in their lifetime. That's pretty huge. So me as an integrative cardiologist, I treat my diabetics as if they have heart disease, even if they've never had an event. I just treat them aggressively like that. And I explain that to them why it's so important. There's another kind of a new group of people that I'm certainly treating, and that's people that have positive coronary artery calcium scans. And this is an ultra-fast CT scan that's done usually at major medical centers. I happen to go to Harbor UCLA for my patients. And it's a great test. It's very fast. It detects calcified plaque in the coronary arteries. It doesn't tell you the whole story. It doesn't detect soft tissue plaque, and we can talk about that later. But it's very, very good at detecting calcified plaque in the arteries. And if you have a positive scan, you've got coronary disease by definition. And even if you don't have symptoms or have no manifestation of the disease, I treat these patients aggressively. That's basically doing primary prevention, but it's based on a test that tells me that there's coronary disease. I'm not just willy-nilly treating patients with medications to get their levels down. So again, it's about knowing your risk. Um, so in these high-risk patients, what is the treatment goal? And I have to tell you that I agree with traditional cardiology here. We want to get that LDL cholesterol in the 60 to 70 range because and that's not just some made-up value. We've known that for years. This dates back to like the Helsinki Heart Study, and then certainly the Forest Study in the 90s, which stood for the Scandinavian Simvastatin Survival Study. That had 4,444 patients. I'll never forget that. And they randomized them, and they found that those that were on statins, these people that had known heart disease, that there was decrease in any secondary event or a further progression of disease. We know that for a fact. So I don't fight science when science is there. So when it comes to secondary prevention, people with known heart disease, I agree that's those patients we should get to the low levels. And that's the goal that I usually use. Now, there's a couple of tests that I think it's a couple of measures, actually, measurements that are not in that traditional lipid panel. And one is LDL particle number. And LDL particle number, it's about the number of LDL particles, not simply the amount of cholesterol in the particles themselves. It's actually the number. And it's important because it's been shown that the particle number has more statistical significance actually in prognosticating worse disease than just LDL. And I'll give you an example. This patient that just recently came to my office. LDL was like 75, which is pretty good, right? And here's a poor man's way of doing it. You just take a 0 and add it to the end. So you would think if the LDL was 75 and you add a 0, it should be like 750, right? Person's LDL was like 1560, almost twice what it should be. So this patient has significant LDL particle number, and that's not a good prognostic sign. So LDL particle number is important. And also, probably more important, is LDL particle size. And all you got to remember is one thing for me: bigger is better. The larger the size of the LDL particle, the less likely it is to get oxidized and then form plaque in the coronary arteries. We're talking like 30 to 40% difference. So oxidized LDL, which we see in those with small, dense particles, tend to have a much higher incidence of plaque formation. So they're higher risk. And how do you know this? Because you have to order special testing. Usually the tests that I use are either Cleveland Heart Lab, which is now Quest bought them out a few years ago, and Boston Heart Diagnostics, both excellent labs, excellent reputations, and they do excellent work. They're kind of like the gold standards when it comes to advanced cardiac testing. You will not know these by guessing. You really need to just have the test done. And so you have to find doctors that know how to order these tests. I will tell you for a fact that your average internist and your average cardiologist is not ordering these tests. So you have to ask for it. And if they don't want to do it, well, you got to find someone who does, because there are many of us that believe in advanced lipid testing. And there's no reason why you as a medical advocate can't get that for yourself. Another thing I want to briefly mention is LP little a, lipoprotein A and little a in parentheses. And that also is important to know, especially in younger individuals. And why? Because it's extremely sticky and inflammatory, and it forms plaque in the arteries. It's not a good prognostic sign. And I always do it usually on the first time I see someone to get an idea of where their LP little a is. And it's a simple test to do. And it's important because it tells you about the risk of an individual patient. And that's what we care about. We care about the risk. So that's the LDL side of things and the high risk population. Now, what about HDL? I love HDL. HDL was always thought to be the healthy kind. And I've always believed in HDL, but it's years ago, there's been at least 3 studies that I can recall that actually said, okay, well, we got to find a drug that could increase HDL because that'll make the patient do better, right? Well, it was wrong. There were at least 3 studies that come to mind that were done, and all 3 of which were halted because actually the patients did worse. There was increased incidence of heart attacks and I think even death. So we have never found a drug that can increase HDL that has a positive impact on survival and less events in cardiac patients. So what about HDL? Okay, well, like I had a patient today says, my HDL is 125. That's great, isn't it? I said, well, not necessarily so. Now, the old thinking was that the higher the HDL, the better. Just like the lower the LDL, the better, and the higher their HDL, the better. But we have found in recent years that doesn't really impart a major difference. In fact, it can be a detriment. So the ideal HDL level should probably be 60 to 80, maybe 90. It's now thought that anything much greater than 90 is actually not beneficial and may actually be harmful, which brings me to my next test. Now we can do tests about HDL functionality, the function of the HDL, which was never done before. Cleveland Heart Lab is doing that now, and I suspect there's labs will be doing it as well. So now we can look at the functionality, because HDL can be functional, which is good, or dysfunctional, which is not good. And the big thing is it's called the cholesterol efflux capacity, CEC. And the higher the capacity, then actually the better the prognosis. Because what we want the macrophages, which are these cells that engulf cholesterol and start making plaques in the arteries, to actually be able to give up that LDL cholesterol to the HDL. The HDL can then bring it back to the liver, where it can dispose of LDL cholesterol. So think of HDL as, we call it, reverse transport. It actually takes it away from the circulation, brings it to the liver for disposal. But it really depends on this new thing called cholesterol efflux capacity, or CEC. Again, that tells you that it's a functional HDL versus dysfunctional. Also, functional HDL is not inflammatory, dysfunctional is. So you're going to be hearing a lot more about HDL in the future, and I'm really excited because I've always thought inwardly that it's a really important thing, but we just haven't had the data, and we're getting it now. So what about everybody else? I've talked about high risk, right? What about regular people? And I personally think people that don't fit in these categories are relatively low risk in most cases. And why should they be on statins? Why should they be on medications at all? That's where I really exhaust lifestyle. And by the way, I also exhaust lifestyle in my high risk patients. That's always number one in my book. Lifestyle, lifestyle, lifestyle. Diet, exercise, stress management, rest. But in these patients that don't have documented disease, that are not at high risk, they don't really need to be on medications. That's me. And if you look around, if you look at all the people on statins, what's the most widely prescribed statins go to? Middle-aged women. Why? Middle-aged women they're very compliant. They will take medications. I see so many people on statins. And one of the things I try to do after I assess their risk is to get them off, because I think it's unnecessary for a lot of people to be on statins. So again, it really depends on your risk. So that's it. I mean, really, it's all about knowing your risk, not how low you can go, and then going from there. And that's what I want all my medical advocates to do. So now I'm open for questions. And so please fire away, because this is one of my favorite topics. Oh, good. I already got something. With my glasses on. For those of us that need glasses, I heard there's a link between oxidized LDL and LP little a. If you have your LP little a, do you need an oxidized LDL level? That's a great question. I don't think it's ever been fully addressed. We know that both of these, LP little a and oxidized LDL, are sticky inflammatory particles. So we know that they both are plaque formers. As far as two together, I do see the two together, which I guess you could call it a double whammy. The problem about LP little a doesn't have a distinct treatment. Okay, it really doesn't. You can use niacin, but it's not improved with diet or exercise. It's purely genetic, so it's like a bad gene. And so what I try to do is treat everything else. There's so many other things that I look for when I'm treating someone with coronary disease. If I can't get out the LP little a, I'll try to get everything else. I should be able to treat the oxidized LDL. Why? Not just with drugs, also things like garlic and olive oil. They help reduce the oxidation of LDL. So there's a lot of natural things out there that you can take to help, decrease the oxidation of LDL. Okay. Are there any natural supplements that are good for lowering cholesterol? Yes. One of the things I like is, well, first of all, there's also red yeast rice supplement, RYL. And it's been around for years. In fact, the very first statin, some of you may know, are old enough, I was a fellow when this came out, Mevacor. Lovastatin came out in the mid-'80s. And it was derived from the red yeast rice plant and from China. And it's not surprising, because a lot of pharmaceuticals originally came from botanicals. But then when they're brought to the lab and they're put in with fillers and all kinds of other things do change. But I do use red yeast rice, and patients that don't want to go on statins. Now, keep in mind, it is a precursor to a statin, so you can get some of the statin-like side effects, but much less so than using an actual statin. So I do use a lot of red yeast rice supplement. I use niacin. And I'll talk about niacin in a minute if you guys want to know. I use a lot of niacin, which is actually a vitamin. It's vitamin B3. However, when we use it in the doses we use it, it kind of looks like it's kind of more like a drug. But niacin is very useful. I have a product on my own called Cholesterwise for HeartWise, and the basic major ingredient is bergamot. Bergamot is from a citrus plant. It grows in southern France and Italy. And it's been shown to be effective in decreasing cholesterol, LDL cholesterol. So I use it with quercetin, with a natural anti-inflammatory agent, and grapeseed extracts. I use those together. If you do use bergamot, you want to make sure you have 1,000 milligrams. That is the number you must have to, have a difference on making cholesterol. Those are the ones that I like to use on a pretty regular basis. Coenzyme Q10 is a supplement that may help. Fish oil, there's like a potpourri of things that I use that I combine for overall cardiac health, but they can have a positive effect on your cholesterol level. Okay, thank you. Put my glasses on. Have there been any studies showing a correlation between high cholesterol and dementia? Wow. Okay. I've never seen. Now, it's true with hypertension. We're getting more and more information, research out that uh, poorly controlled hypertension, especially starting in middle age, for some reason about middle age, poorly controlled hypertension can lead to dementia and also atrial fibrillation, which is another reason why I like to keep my patients in normal rhythm. Excuse me. I haven't seen a study really. I'll have to look that one up. It's a great question. I haven't heard of that link before. But it seems to me there probably could be a correlation because oxidized LDL is just certainly not a good thing, right? And it also could lead to plaque formation. And again, we're talking the carotid arteries and the small vessels of the brain. So actually, I'm answering my own question here because it's not just Alzheimer's. Alzheimer's is the most common cause of dementia as we get older. But there's also small vessel disease. And sometimes they actually can look alike. And you can tell a differentiation when you do a CT scan. You'll see little microinfarcts, we call it. So actually, I think the answer to your question is right. I haven't reading about it, but it makes sense because cholesterol plaquing can lead to infarcts in the brain, and that would certainly have an impact on your cognitive ability. So thank you. Okay. How does sugar alter? Sugar is like the nemesis. I mean, to me, it's like the worst. Um, for years, cardiologists. I mean, this dates back to in the '90s. Everything was like, low fat, high carb, low fat, high carb. Okay, so the country got fatter, and now we have more diabetes than ever before. It's become a true epidemic. We were really totally wrong. The research behind it was not great. And now we see the aftermath of metabolic, just gone awry. Metabolic problems gone awry. So I think sugar is a problem. Sugar can definitely affect. There's more and more evidence coming out now that sugar actually does have a role with plaque formation as well. And here's the most important thing: sugar is inflammatory. Okay, I tell people that eating sugar is like pouring gasoline over a fire. I mean, it's and think of your arteries as being on fire. Okay, so again, it's very inflammatory. Anything that's going to increase inflammation in the arteries is going to lead to heart disease. So it has a major role. Thanks. Let's see what else. Oh, okay. Here's a good question. Is there ever a reason to just do a simple lipid panel? Actually, no. Actually, there is in a way. Sometimes when I first see a patient, I don't know their history. And if I know it's a patient with a positive cardiac history or positive family history, I'm going to start off with Cleveland or Boston Heart. But if it's a patient I'm seeing for a first and it's just, I don't really know their history, I'll just get a routine panel. And if I see anything that looks fishy to me, like high a low HDL or triglycerides that are high or high LDL, I'll probably go ahead and do a repeat panel. Also, when I'm putting someone on medication, let's say it's a statin, or we have these new medications called PCSK9 inhibitors, they're monoclonal antibodies, they're biologics. You give it twice a month and it lowers LDL like by 45 to 70%, which has been helpful in really high risk patients. But if I just want to see where they're in the right direction, I'll just do a simple lipid panel because it's expensive to do these tests. You don't want to do these tests all the time because insurance won't want to pay for them. So I am selective. So there's an occasional instance when I'll do a simple lipid panel, but again, it's maybe for the first time I see a patient or when I'm initiating drug therapy and I want to see whether I'm going the right direction. Okay, next question here. How do you feel about nitrous oxide? Something it's great. Nitrous oxide. So nitrous oxide is associated. They're coronary vasodilators. So it's not first in my line of. I don't like routinely give nitric oxide, but maybe I should. We haven't. I've always had this question about, well, what's the right one to give? What's the proper dose? And I've never seen any compelling evidence that's really swayed me in that direction. Do I think it's healthy? Yeah, but it may be that you need to have really large doses. And a lot of the studies were based on like IV supplementation, where we're not going to, give patients intravenous nitric oxide or precursor. So I think it's probably a very positive thing, but it hasn't been really detailed as to how effective it really is and how we should do it. It's a good question, though. Do you think PCSK9 inhibitors lower cholesterol too much? Great talk. Great question. Yes and no. Again, it all depends on the risk. Now, I really don't go below 50 in my patients. Okay, now there's a lot of cardiologists, one that comes to mind who's very well known at a Cleveland clinic. I won't say anymore. And this person thinks cholesterol in the 20 or below is fabulous. We can't get it low enough. Basement Barking levels of LDL cholesterol. And I don't agree, because LDL cholesterol is not some terrible villain. In fact, you need it. The only way to get cholesterol to various organs, now we don't want to go into the arteries per se, but we sure as hell want to go into the heart, to the brain, because without LDL cholesterol, you'll never get cholesterol going to the brain. And it's used for two main reasons. One's for myelin sheath, which protects the nerve cells. Okay, other is making new nerve cells. Like when I was a fellow and when I was a student, we didn't know that you could even make new neurons. Now we know that neuroplasticity and the making of new neurons is a very real phenomena. Well, guess what? Without LDL cholesterol, it just ain't going to happen. And I don't know about you. I don't want a good heart with a bad brain. So I do not want levels of 20 and 30. I'll go as low as 50 in very high risk cardiac patients. I mean, really high risk, that have, progressive disease. And I do want to say one thing that's important. And I'm telling this to my patients. I'm doing a new kind of test now that some of you, I've mentioned it before on some of my YouTube. That's called a pulse test, PULS. And it's like the coronary artery calcium scan is a great test, because it tells me, is there any calcified plaque in the arteries? If you got it, it's positive. Okay, but calcified plaque is not a new thing. It's been there for a while. You don't just develop plaque and all of a sudden calcium's in it. It's a process. It's an evolutionary process. So first you have like a break in the endothelium, which is the inner lining of the blood vessels. Then oxidized LDL gets in there. Then cholesterol plaques get in there, and then you have smooth muscle cells migrating in the area. Then finally you have calcium going in, being laid down. That helps to contain the plaque, because the more contained it is, the less likely it is to break off and cause a stroke or heart attack. But it doesn't tell me about what's happening now as we talk. So if I want to get more information, I'll do this pulse test, which doesn't visualize soft plaque, but it tells me with various biomarkers what's going on at the cellular level, at the vessel level. And that's really what I want to know. Forgot my point now. Anyways, so it's all about getting the right information on the patient, because now that I'm seeing, this is my point, now that I'm seeing pulse tests, I'm seeing calcified tests that are stable. I'm doing stress tests on the patients, normal. And I see that their cholesterol, their lipids look good, their inflammation markers are down, and their metabolic picture is pretty good. I had a patient today that's like, oh my God, he can't do any better, right? And then I did his pulse test, and it's like high risk. That means we still have work to do. So then I'll start treating now patients. I'm looking at supplements now that work at the vascular level, which is where this whole thing began. So I want to just make sure I say one thing before we end, and that is, this is a progressive disease. It's like cancer. I mean, it's progressive. Heart disease, coronary disease is not going to go away. Okay, the nature of the beast is that it's going to keep expanding. We know this. I know this from the calcified scans that I do in many patients, definitely the pulse testing. So the way to get a handle on it is to just accept that fact, work with an integrative cardiologist, and do everything in your power to limit progression of disease. And it can be done. It's work, but it can be done. And that's kind of what I'm all about. Okay, it's my take-home message for today. Shellfish is high in cholesterol. Is it balanced HDL, LDL, or just LDL? Okay. First of all, I don't really care. Shellfish is so low fat. Who cares? I mean, for years, the American Heart Association is still saying this crap about you should limit your eggs. You should watch shellfish, lobster, and shrimp is out. First of all, they're so low in fat. What are you worried about? Number one. Number two, I think finally in 2015, this government agency, I forgot the name, it's in my book coming out, is that it said, okay, eggs really aren't that bad. Here's the story. I don't care how high cholesterol is. Cholesterol in food does not equate to cholesterol in your bloodstream. It's not. I mean, I'd worry more about sugar than I would about shellfish or eggs any day. So please, those are old myths. I'm glad you brought it up, because that's old thinking that if you listen to the Heart Association, and God bless them, because they've been around since 1926. They've done a lot of good things, but they are not up to date with a lot of their recommendations. And they're still saying saturated fat should be no more than 7% of your entire daily diet. I mean, it's crazy. And it was never based on science. So eat all the selfish you want, as far as I'm concerned, and you can have 3 egg yolks a day. I don't think it's going to make a difference in your cholesterol. That's my feeling. Okay, what? Okay, that's a great question. What else do I have here? Oh yeah, okay. So people ask me, so who cares if it's small vessel, small particle size, or large particle size? Is there a difference in treatment? And the answer is yes, there really is a difference in treatment. And when it comes to lowering LDL cholesterol and LDL particle number, statins work fabulous. I mean, bar none. They do it quite nicely. I mean, with the usual statins, you can get your LDL cholesterol 30%, your LDL cholesterol 30 to 40% lower, sometimes even 50%. I've seen some dramatic responses to statins in select patients that I think really need it. But with you talking about a mixed picture, such as low HDL, high triglycerides, and small dense particle size, and it's kind of a triad. You can give someone 80 milligrams of Lipitor. It's not going to make a small particle into large. So when I see people with a mixed picture, I want to make that small into large because bigger is better, right? So what do? Statins don't do it. I use niacin. Niacin is, again, a vitamin. I'm using it in large doses, and I try to that can be very effective in actually increasing the size of the LDL particle. I often will have to use a statin with it or add a statin later. I have, since I do a lot of work with lipids, I combine therapies, but I want to get that LDL particle as large as I can because that'll decrease the risk of oxidation. And at the same time, I'm working on decreasing the LDL and the LDL particle number. So it's important. Niacin is also very interesting. So it does a few things. It will lower LDL like statins, but not nearly as effective. Okay. But it can decrease triglycerides. So if you have a metabolic issue, it can be helpful there. It can increase HDL. I'm not quite sure about HDL functionality since it's a relatively new test, but it can increase your HDL number and also have a positive effect on decreasing LP(a). There's nothing else that works on LP(a). Although I will tell you that there are studies coming out now, usually I think from UCSD, working on biologics that can decrease LP(a) like within 5-6 weeks by like 50%. That's going to be truly a game changer. Like PCSK9 inhibitors are kind of a game changer. This will really be a true game changer because we thus far have no real treatment to lower LP(a), and it's not uncommon. I probably see it in 30% of my patients, if not more. And as far as small particle size, at least 40% of my patients have a mixed picture. That's why I don't understand why doctors just do that simple lipid panel. In patients with high cholesterol, you need to work it up. Okay, let me see any questions I have. We talked about supplements. I think that's, particle size. I think that's it. Any other questions? We talked about supplements to make sure I got all my questions straight. Good. I think we got it, guys. All right. Thank you. Thank you so much for attending. Our next time will be 2 weeks. It'll be this 2 weeks from now. And I've got a couple of really cool ideas in mind, but haven't figured it out yet. So I'll let you know then. So please subscribe to my channel. And if you see any of my videos, I appreciate if you just press the like button. There's an algorithm that works that kind of helps increase my audience. And I'm trying to build that. Also, we do consultations at heartwise.com. I'm also on Instagram, which is Doc H. Elkin. I'm trying to be pretty active with social media. Thank you so much for attending. I'm very grateful. And we'll see you in 2 weeks. Good night.